Hello, good afternoon, everyone. My name is Trevor Jennings, and I'm the Senior Program Coordinator for the iREACH program with the Association of Immunization Managers, AIM. I'm just going to give it a few minutes for everyone to join, and then we'll get started. All right, I think we're going to go ahead and get started now. So like I said, my name is Trevor Jennings, and I'm the Senior iREACH Program Coordinator with AIM. So we're really excited for this webinar today. Thank you all for joining us on this afternoon. So this webinar is going to focus on CDC's Health Equity Guiding Principles for Inclusive Communication. And during the webinar, Dr. Susan Laird, who we have with us today, who is the Health Communication Specialist in the Office of Communication Science, will provide brief highlights from the guiding principles and offer tips on how you all can apply them. So these principles are intended to help professionals in public health and healthcare, and particularly health communicators, ensure that their products and strategies adapt to the specific cultural, linguistic, environmental, and historical situation of each population or audience of focus. And a little bit more about the health equity guiding principles. So achieving health equity requires focused, intentional, and ongoing efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and healthcare, and eliminate preventable health inequities. So as part of that effort, CDC's Health Equity Guiding Principles for Inclusive Communication emphasize the importance of addressing all people inclusively and respectively. So I talked a little bit about who these were intended for earlier. And so in this session, we'll explore the background, development, and need for these principles, how this implementation is important, and what those who create and review communication products can do to help apply these principles across their health communication work. So like I said, today we have Dr. Susan Laird with us, who is a health communication specialist and project director in the Division of Communication Science and Services in the Office of the Associate Director for Communications at CDC. She's also the communications director for CDC's Public Health Grand Rounds and the historical series We Were There. She has served in a variety of roles in the 15 years she has been at CDC, and recently served as principal deputy at the Joint Information Center for COVID-19 response. Currently, she also serves on the work group that developed and launched the CDC's Health Equity Guiding Principles for Inclusive Communication. Former marketing and advertising executive, as well as an award-winning broadcast writer and producer, Dr. Laird made a 180-degree career change, earning her bachelor's degree in nursing from Georgia State University in 1997. She became certified in critical care, trauma, disaster management, and emergency response while pursuing her master's degree from GSU in adult health nursing, which she completed in 2001. And then in 2020, she completed her Doctor of Nursing Practice degree with a project focused on preparing nurses for roles in end-of-life decision-making. In her clinical career, Dr. Laird has advanced from bedside through leadership roles in emergency departments, taught in nurse residency programs, and lectured as faculty at Emory and Georgia State Schools of Nursing, where she is currently part-time faculty. She has served on multiple ethics committees in hospitals and healthcare systems over the course of her nursing career, and Dr. Laird is committed to health equity after witnessing the impact of disparities firsthand in her clinical work. So we are so excited and happy to have Dr. Laird with us today to talk about the guiding principles. And without further ado, I will turn it over to Dr. Laird. Thank you so much, Dr. Laird.
Thank you so much, Trevor. That's exhausting. It's no wonder I'm tired. You know, when you get this old, you get a lengthy bio like that. So I promise to be more interesting than my lengthy history. I'm going to take a moment here to be sure I'm sharing my slides. And then we will.
Yep, we can see them.
There, how's that?
Everything looks good.
Okay. Do I need to pin myself? I'm not sure.
I can pin you.
Okay, that'll be good. So again, I am delighted to be here today, and I really want to thank you for this opportunity. What we're trying to do is share our passion and commitment to this work in a way that will entice you to join us in the effort. So I'm going to try to cover a lot of ground in a short period of time, and know that our ultimate goal is to enlighten as many people as possible just to consider looking at the world through a health equity lens. So thanks for showing up. So I'm not going to read this to you because you already know why you are here. Atul Gawande is a personal favorite of mine, and I appreciate and agree with his take on changes and improvements in healthcare delivery. In his first book, shown here, he states it clearly. If we just don't know, then we do the best we can. But when we do know and we don't do the right things, then we've got much work to do. And the work in health equity and inclusive communication is designed to put us all in the know. So why is CDC doing this and why now? Well, when I joined CDC 15 years ago, there was a working group focused on defining health equity. And I remember one of my colleagues talking about the intense discussions. So this work is not new, but there is a renewed focus, and we're hoping you're all ready and willing to share and engage in this work from your own distinct vantage points. Health equity is a public health crisis, and we need to collectively help people understand that. So I hope you've taken a moment to look at the guiding principles. We started on this project just over a year ago. I was part of a very small work group. We engaged subject matter experts across the agency, and we grew to about 16 people in the work group. We worked in probably one of the most collaborative endeavors I've ever had the pleasure to work in. We also practiced what we preached. We engaged a variety of communities, internal to CDC and external partners for validation, starting with our CDC internal work groups and then expanding to subject matter experts from university settings, healthcare settings, American Medical Association, American Public Health Association, et cetera. So from start to finish, within 3 months, we launched to both internal and external audiences. So most of you are probably already familiar with the social determinants of health, and we know that these have had a major impact on people's health, their well-being, and their quality of life. Examples are shown here of what social determinants include, but it's important to remember that they contribute to wide health disparities and inequities. For example, people who don't have access to grocery stores that have healthy foods are less likely to have good nutrition. And that raises the risk of health conditions like heart disease, diabetes, and obesity, and even lowers life expectancy to people that have, compared to people that have access. So inequities and social determinants are the driver of inequities in health outcomes. Now, race is one marker of inequities in social determinants. We found sometimes that when we talk about health equity, many people consider only race as a factor, but there are several. So what does health equity really mean? Well, in order to have us all be on the same page, this is our basic definition: the state in which everyone has a fair and just opportunity to attain their highest level of health. So then what are health disparities? Well, the key word for me in the disparities is preventable. These are things we can change, primarily by addressing the social determinants themselves, the actual conditions. So although most are preventable, maternal deaths have been increasing in the United States since 2000. And as US policymakers and healthcare delivery system leaders seek ways to reverse this trend, countries that have achieved lower maternal mortality rates may offer possible solutions. So we're at the top of the list in developed countries for maternal mortality. What in the world is going on here? And from the beginning of the COVID response, we were able to quickly see that race was a factor in disparities for hospitalizations and even deaths from COVID. Again, what's the why part here? And note that while COVID did shine additional light on the issue of race and social determinants of health, it's not just COVID. We've known that there were much higher numbers of maternal mortality in Black women for years, and these issues often reflect the historical impact of the social determinants. I imagine that you may have already seen this as far as the addressing the barriers to vaccination in rural areas. Rural contributes greatly to the social determinants of health as well. And I just saw this the other day from the Kaiser Family Foundation. And when you look at the percentages of people that have already received their vaccine dose, it's very clear that we have a higher rate of people who have not yet been vaccinated in the Black population. So is this hesitancy or is it access, the social determinants? What's the reason behind that? Sorry, I'm missing a slide there. This slide just came out yesterday. You may have seen the vital signs already, but again, it was just released yesterday. When you look at the overdose deaths, again, our American Indian, Alaska Native populations and Black populations are higher there. So in my current work at CDC, we're really starting to pay much needed attention to accessibility. Sometimes when we say disability, we only think of what we can see, but there's much more to accessibility than disability. Maybe people live in areas where they don't have internet access and they can't take advantage of your important information. That's an accessibility challenge. Maybe the person is not in a wheelchair, but perhaps they have a learning disability. We may have to expand our thinking a bit. So let's talk about why words matter. We know that stigmatizing language can actually hurt people by influencing other people's judgments. So if we define stigma as an attribute, behavior, or condition that's socially discrediting, stigma is infused by two main factors, cause and controllability. In terms of cause, when people believe an individual is not responsible for the attribute, behavior, or condition, meaning it's not their fault or they can't help it, then stigma is diminished. But research has shown that our use of stigmatizing terms may influence judgments, basically that a person is either good or bad, worthy or not, as well as the need for punishment versus treatment. It's really important to remember that we personally cannot determine the level of pain stigma causes someone else. So let's take a look at this example.
Susan, I'm so sorry. I hate to interrupt, but your sound is a bit choppy. I'm wondering if you could maybe turn your microphone off and turn it back on, or see if something needs adjusting there. It's just a little staticky. Sorry about that.
That's okay. What is it? Is that an improvement at all?
Not really.
I don't know what's happening with that.
Okay. No problem. Sorry, we were just getting some notes in the chat about it, and I could hear it too. You can go ahead. Sorry about that.
Okay. Hopefully it will improve. My connection looks okay, so I'm not sure what's going on.
Is there another way, another speaker, Susan, or are you using?
I can. Well, let me see what I can do with this. Hang
it
on.
might be the headphones, actually.
That's supposed to make it better. So if I take these out, is that an improvement at all?
No.
Not really.
No, it's just kind of gravelly. I mean, we can hear you. It's just a little distracting.
Sorry, I don't have anything else I can use.
Okay.
I will. I'm not sure how to handle that. It's not happened before. This is a good good strong headset, so I don't know.
Sorry, maybe one last thing we could do is, could you try to leave the webinar and then come back in? I don't know if that will work, but
or it could be your bandwidth. Do you want to try turning off your camera?
Let me try that. Does that help at all?
no.
I use this system specifically because it is a better system than the other one. Let me try a different. Let me try a different headset real quick. Bear with me while I try a different headset.
Okay, sorry about this.
No, I'm sorry. I don't know why it wouldn't. This has not been a problem. Any improvement there?
Not really, but it's okay. We can just move forward. We can hear you. So
I'm sorry, Trevor. I don't know.
no problem. It's not your fault.
Okay. Um, I was talking about the stigma and the way we refer to people and how words can hurt. And so the example that I was just showing in the previous slide gave a little definition. So here, when we had a person that was referred to as a substance abuser, they were perceived to be less likely to benefit from treatment, and they should be punished for their activities. But when that same person is said to have a substance use disorder, then they would be provided intervention. So this particular result details the differences in how people were perceived by how we addressed them. Okay, I changed my system now, hold on. Maybe one of the most profound examples of stigma has been directed towards people living with HIV and AIDS. From the time the virus was discovered, this stigma has been directed towards people living from the time, I'm sorry, I got really distracted when I lost my flow, but I'm going to get it back momentarily. The stigma for HIV and AIDS continues today, and it impacts not only those with actually having the virus, but also the LGBTQ community. And now we have another opportunity for stigma for gay males with our monkeypox. And maybe we'll do a better job of minimizing the impact with this one. So health equity and health literacy and accessibility go hand in hand. Using health literacy principles is one step in addressing inequities. For example, we can use plain language, testing materials with intended audiences, providing translation services for people with limited English proficiency, and designing websites so they're accessible to people who use assistive technology. When we use all these lenses for all products, we're able to help our communicators work towards improving their overall materials, meaning that, first of all, one size does not fit all. You need to know your audience. What's objective is observable fact, subjective, perspective and preference, and then being open to improvement, and remembering also that accessibility doesn't mean only 508 compliance. So let's dig a little deeper in the concept of using a health equity lens. What does that mean? Well, to me, the key word is intentional. Look at your messaging and materials to identify potential positives and negatives that may impact your audiences. You want to be more effective, right? So get input from the intended audiences. Just ask them how they want to be identified, how we can be useful. That's what we did in the development of the guiding principles, and that's what we're suggesting that you do in your own workplace. These are the core components that you would use to ensure you're using a health equity lens. And we'll talk a little bit more in a minute about intersectionality. Now, these are the questions to ask when you're going to apply a health equity lens to your products and services. First, most of us in our respective work environments are aware that all of these are contributing factors. And some of them may even seem redundant since they all lead back to the same problems. But I want to point out that the significance of our own assumptions and biases should not be overlooked. These evolve from the way we were raised, our exposures to different cultures, different experiences, and they all play a major role in how we perceive others, both positively and negatively. A health equity lens helps us see beyond our own worldviews by engaging our communities and populations of focus in the decision-making process. People in groups appreciate being asked about their worldviews, and when we ask, we usually learn something. Finally, if you do this activity, this action, will you unintentionally cause problems? Are you overlooking risks or benefits? Is your message saying what you want and need to say? And are you staying within the appropriate context? I had to share this with you because I was looking for a graphic that would demonstrate what intersectionality means. So I started with cdc.gov, right? And this is what came up first from the Injury Center, a call to enforce red lights. clearly we need to look a little deeper. Now, a clear definition of intersectionality is that people often, and in fact usually, belong to more than one group. So people may belong to more than one group that has historically and currently faced discrimination. We should consider this in our analyses and our communications. As one example, a Black woman may experience discrimination based on her race or gender. She might identify with experiences of white women as well as with the experiences of Black men, but her experiences as a Black woman might differ from either of the other groups. Our sister agency, ATSDR, literally wrote the book on community engagement, and I highly suggest you go check out their website. They've got a lot to offer. There are fundamentally 9 principles. All aspects of community engagement must recognize and respect the diversity of the community. Awareness of the various cultures of the community and other factors affecting diversity must be paramount in planning, designing, and implementing approaches to engaging the community. So the engagement can only be sustained by identifying and mobilizing the community assets and strengths, and by developing the community's capacity to make decisions and take action. Now, there are some people that think that generations no longer make a difference, that we've all kind of blended together at this point. But I think we're leaving out a significant contributing factor if we don't understand how important the differences are. Generational perspectives are highly important, especially now where we're working in a 4-generation environment. Understanding the different points of view will help us frame messaging to fuel change. In Lynn Lancaster and David Stillman's book, entitled When Generations Collide, they identified drivers of perspectives based on when people were born. So, for example, people from the Depression era may have experienced hunger. In my generation, the death of our president by assassination was a very big influence on my perception as a child. My own children distinctly remember 9/11 as a very major change in their lives. And so when you look from another person's worldview, you're going to discover that we all have a different perspective depending on where we stand there. Another area that needs to be addressed is humor. Last year, People magazine did a feature story and interview on Gabrielle Union, and they asked her directly about the impact of racism in Hollywood. This is a great example. Blackface in musicals were very popular in the 1930s and 1940s, and children of parents who grew up in their households would not always know that blackface is inappropriate. So there have been multiple examples in the last year or two where well-known people, frequently political types, are showing up in parties in blackface. It's just not funny. It never really was funny. So I'm sure if you think about it, you could come up with other areas where our perception of what's funny is changing over the last several years, as it should. Now, in the process and after the launch of the guiding principles, we received both feedback and pushback. I guess the difference in those two are primarily that the feedback was constructive and we made changes to reflect good ideas. The pushback, not so much. Pushback came to our email box. Some of it was really harsh, even mean. A few even used our suggested words to basically attack us. I don't know if you're a Super Bowl watcher, but this past year, Billie Jean King, who's the first female athlete to receive the Presidential Medal of Freedom, tossed the coin to mark the 50th anniversary of sports gender equality legislation, which was Title IX. And in her acceptance for the medal, she said, it's hard to understand inclusion until you've experienced exclusion. I think it's a good place to start with an understanding that this work is hard and not everyone will be supportive and not everyone will be understanding. So let's talk about the guiding principles and what they are not. First, it's important to focus on the foundational concepts, not the preferred terms. The terms are just examples. And as we continue to say, they're not prescriptive and they are certainly not the only options. There are no mandates here. It's a reference. You don't have to use these exact terms, but we think you should give them a chance. We learned that there were supervisors at CDC that were telling people that they had to use these terms. So I want to repeat, there was never a mandate for us, and we would suggest they wouldn't be for you either. And you may find better terms that apply to your population of focus. So mostly we were emphasizing the importance of addressing all people inclusively and with respect. So these are the foundational principles upon which the rest of the work rests. Reframing messaging to be aware that what we say about others has an impact, and we want those messages to connect with our audiences. We've referred to target audiences and vulnerable populations for so long, it's a habit. And changing habits takes effort and energy, and it won't happen overnight. So it's important, again, I want to stress that these are recommended terms to just start the thinking about what's going to work in the communities where you want to make an impact. People tend to focus on those actual words again versus the intent. So listen to your audience and use the lenses that we've described. One great example we're finding is a lot of controversy over the term pregnant people, for example. It shows up in a lot of the pushback we received, even though we didn't include it in the guiding principles themselves. The intent is to be inclusive towards a transgender audience, maybe, but the risk of offending pregnant women is currently very high. So what we do is weigh the potential impact against our intended audiences, and then we make a decision based on who will benefit the most from the messaging. Mind your adjectives. So instead of saying high-risk groups, you might say groups with a higher risk of diabetes or heart disease. And we always recommend saying people first. Instead of saying the homeless, you would say people experiencing homelessness. So it's a person first language. Now, this quote from business guru Peter Drucker deserves revisiting. It's an old one, but a good one. Culture will rule every time. When possible, translate materials into the preferred language of your audience. And as we've said before, engage your community. There's a new focus on mental health, and that's really a good thing. Discussing mental health was taboo for a very long time. We were talking about things that we've never talked about before, thanks to people like our Olympic gymnasts, professional tennis players, etc. Now that those celebrities have identified that they suffer from these concerns, it may be less stigmatizing for others to openly discuss the concerns and needs for all of our communities. Now, I'm a person who doesn't relate well to being called elderly, and I have a few pet peeves I want to share with you. As we age, we're indeed at increased risk, but there are miles and miles between me and the nursing home. At least that's, I hope so. So if you want to reach these audiences, think of different ways to categorize people. We're not all sick. One pet peeve of mine, when I am a healthcare provider, but when healthcare providers come into the ER and they see an older person, maybe with gray hair and a few wrinkles, they immediately start yelling, raising their voices in the assumption that the patient is hard of hearing just because they're older. So be aware that age and risk associated are often on a continuum. Risk for many diseases and more severe outcomes do increase with age, and tailor your guidance to specific settings when appropriate, such as long-term care facilities. Signs and symptoms of many diseases may be atypical, delayed, or attenuated in older adults. Caregivers themselves are often older adults and may have additional risks. So use audience-preferred channels and platforms. I want to talk about the importance of choosing appropriate images. Now, this is a search I did in looking for doctors. And what I got was a bunch of white coats with mostly white doctors, mostly males, minimal diversity here. So we're working now for part of our health equity guiding principles website to add a couple of new resources that will help you with image selection. Help you choose better examples to diverse populations and depicting them in a positive light. So a picture is worth 1,000 words. I know you've all heard that before. We want to be sure that pictures and graphics are given equal attention as the words and the language are. So with regard to how we're going to talk to our audiences. And this is the a matrix. As I said, we've got one about to be posted on our website that you'll be able to print out and use yourself to try to evaluate an image or graphic of some kind that you want to use. So you can use it as a checklist and help you think through, am I giving it the consideration it needs to be able to use it? So we have some suggestions for how to implement these concepts in your own work environment and your own life in general. So restate some of the concepts when you're trying to talk to people about this work and not just focus on the terms. Allow opportunities for people to make adjustments. What does that really mean? Going back to one of my previous statements, not everybody comes from the same place to start with. Nothing is set in stone. Practice makes perfect. And what is your personal contribution to the effort? What matters to you? In order to make it stick, you need to start. So we suggest you start using the guiding principles, refer to them before and during development of your communications. Look at the materials through a health equity lens, and then look within your organization and look within yourself before you look outside. This is not a finished process. I don't think we're ever going to be finished, to tell you the truth. It's important to understand when and how culture changes. Listen to learn when culture changes. Incorporate communities into the learning process, our learning process. Build relationships with communities to obtain their input and invite them to be part of solving the problem. Maybe start by taking a look at your website through a health equity lens. It's a good starting point. Look at places where the work needs to be considered. Some of your web pages may need a serious overhaul. Inaction only perpetuates the problem. Taking a general approach will not correct the inequities. Being intentional and specific will. Challenge the status quo. And one of the biggest challenges we have is determining how are we ever going to measure success? How are we going to know that we helped make a difference? It could take generations to make a behavior change, and change takes time. There are policies and procedures in CDC and other organizations that we can leverage. How serious are these organizations on health equity, and what policies can we change quickly? In the area of communication, we can do quantitative assessment of materials that are compliant, numbers of trainings, but how people think and how they interact is a lot harder to measure. So perhaps plain language and clear communication and improved understanding of accessibility will help. Consistency will be a major part of making it stick. We ask that you strive to have an open mind personally and collectively, be willing to listen and adapt to the changing climate, and use a health equity lens across all your work. And please know that not everybody's going to get it. I can share that CDC is a big place, and just because we all work here and that we all work in public health, that doesn't necessarily translate into all of us thinking the same way, talking the same way, or behaving the same way. Maybe you're struggling too. Invite others to the table. Continuously engage colleagues to discuss content and implementation. Increase understanding to obtain buy-in. And remember that forgiveness and encouragement are a lot more effective than blaming and shaming. Ask for help and share your own ideas for improvement. So that concludes my presentation. I'm hoping if I'm able to take down my slides, that maybe that will help with the sound. I'm not sure.
I will say, miraculously, it got perfect, the sound.
I have no explanation, but thank you. I hate it when, I really want to say something that you can stand to pay attention to for a few minutes. So I'll take down these slides and we can, let me find this, stop sharing. There it is.
Yeah.
So let's talk. I hope you have some questions.
Yeah, I just wanted to say thank you so much for that amazing presentation, Dr. Laird. Such an important topic and just very great points that you made that hopefully will benefit everyone on this call. So I'll turn it over to Eric for moderation of the Q&A portion.
Of course. My name is, brief intro for myself. My name is Eric Wengel. I'm from the Urban Institute, and I'm one of the group learning managers from the P4VE learning community. And just right off the bat, I want to echo a lot of the chat right here, which is complimenting the presentation. It was fantastic.
Thank you.
And so to start off, so this is a very basic question. Will these graphics be shared? I know that there's some fantastic ones in here, and particularly the one on intersectionality. I thought that was a fantastic graphic.
I would be more than happy to send these slides, and I hope that you can share them even further. Yeah.
Perfect. Okay.
I'm an open book here.
Excellent. And then, so if anyone has any questions, please go ahead and put them in the chat, and I'll do my best to read them all and get them asked. But in the meantime, so how have these new principles, you mentioned that you've only been working on these for a couple of years. So have you noticed that it's made an impact in the way that like CDC's release communications, even just in the past few years?
Nothing specific. What I can say is that I am getting so many requests for presentations, both internal to CDC and the different CIOs, as well as external. I have 5 of these within a 2-week period. I'm grateful for that. And until we get people to at least listen, and what the kind of feedback I've gotten is that people like the fact that I'm not coming with a hammer approach and saying, you must do this, you must do that. I'm just trying to get people to think. And if you stop and think about the impact of what you're saying, I mean, we would say that if we had a personal relationship with each other. And, you know, I wouldn't talk to you in a way that was disrespectful or unkind. I just wouldn't. So why would I go out there in a public way, in public health or healthcare or any other setting for that matter, corporate, I don't care. I think the same principles apply. Why would I go into a workplace and start being obnoxious because I can? I mean, I think a lot of things that have happened in the last few years have been driven by people in different positions than we are. And, you know, personally, I'm offended when somebody says something that I think is completely inappropriate. And I think another thing that happened that makes this work have more relevance, social media. You know, when you're not face to face with somebody, you know, and you're hiding behind your typewriter or your computer screen, all the manners and the kindness seems to have gone away. So I think if we go back to the way most of our parents raised us, this work isn't that different. We're just calling attention to it. So, you know, I know that's a bit of a reach to say, and I'm certainly not, I think social media can be extremely valuable, but I also think we have some responsibility in the areas where we work to say, you know, we're going to be more respectful of people. I mean, I've seen people say things in those environments and I'm shocked, you know, and I've been around this world long enough not to be shocked, but I continue to be surprised on a daily basis at how mean people could be. As I said, when we launched this work, we got a lot of pushback, a lot. And it was, you know, it didn't bother me because, as I said, when you get to, I'm an ER nurse, there's nothing I haven't seen or heard. And, you know, but some of my colleagues that were working on this project with me were astonished. And I was like, you know, we're putting stuff out there that makes people think, and that's not always popular. But I could go on about that topic forever. You should ask me another question.
So I'm going to take one from the chat here. So you mentioned that measuring people's interactions and mindsets is difficult, right? So how can we measure this progress?
Do you mean how are we going to know whether we've made a difference or not?
I think so. I think that's what the question's getting at.
You know, we're struggling with that. You know, CDC, the science and the evaluation, and you know, how many people got vaccinated and how many people didn't. And, you know, there's, and what population, you know, there's a lot of that kind of measurement. And when you stand back from this work and you want to know that you changed behavior, I mean, when we work to stop smoking, we know that cigarette sales are down, you know, but people may come into the realm where we're trying to work with this thought process and they may give lip service to the work, but then they may go home and use language that would not fit within what we're trying to say, that's not inclusive or not respectful. And I think it's important, you know, I didn't spend a lot of time on the generational thing, but let me just share with you a personal example. My father, he's deceased, but he fought in World War II in the Pacific Theater. And he absolutely despised Japanese. There was nothing we could say, do to influence how he felt and what he thought, or the experiences that led him to feel that way. And I share that because I think it's important to understand that we are all a composite of those experiences, including how our parents raised us. You know, I was not raised with any kind of a bad opinion about Blacks, but the Japanese, now that was a whole other story, you know, and only Japanese. You could be, you know, Vietnamese, he was fine. You know, there was just no reasoning with him. So knowing that we have to start from that position to understand where somebody comes from, how we go about changing their mind, you know, that's the question of the day for sure. I think being mindful of it and using what I said in the end about, you know, no blaming and shaming here, you know, it doesn't work. You know, for me to try to tell my father that he shouldn't feel that way was useless. To try to expose him to a different mindset, he was just older. He was fixed in his role, and so my efforts are working with the rest of you instead. Does that make sense? You know,
Makes sense to me.
Yeah, I mean, you can't. You're not going to have those kinds of moments that often.
Yeah.
I know when I was very, well, I would say 17, 18, my understanding of gays was completely different until I met someone who was gay, who was just exactly like me, you know. But what your mind has fixed, and that didn't even come from my parents, that came from the world at the time, you know, how gays were perceived. So until I met a really nice man who was gay and got to know him and we became friends, then I had the perceptions that society had at the time. So this is a lot of work to do. I'm hoping we can do it faster by having the understanding and the desire to do it faster. That's going to drive most of the success, I think.
So thinking about like misinformation, I mean, this is another question from the chat. So like when approaching people who do have like, and who are ingrained with misinformation, specifically about the COVID vaccine, what would be an example of how to like respectfully tell others that they're like basically to correct the misinformation?
I think you have to start with asking why they feel the way they do. I mean, that would be my first question. You know, what are your concerns about getting the vaccine? What is your concern about making sure that your child gets the vaccine? There's a webinar next Friday that we're doing on the 29th from 1:30 to 3. I'm doing some behind the scenes fielding questions, but it's several federal agencies that and it's experts communicating with directly with communities. So it's expected to have a large audience, and they may be offering some suggestions in there because it's specific to the president's executive order about vaccine accessibility. So you may want to tune into that. But to be more specific to your question, I think if I were a young mother with a 6-month-old child, I might be fearful of the response. Maybe I've been giving a response to a COVID vaccine. I mean, I've probably been vaccine compliant with all the other vaccines that children get in the first 2 years of their lives. So there's a lot of them. But now here's this one. You know, a lot of what I heard was, well, this is new technology. having ready answers that explain in very plain language that the technology sounded new, but it really isn't. It's new in the world of vaccines, which became, I was a child of the polio world where my mother didn't want me to go swimming, which made, I didn't have any place to go swimming anyway, but the idea of a community pool was terrifying to her. And so when the polio vaccines came out, I even remember as a Sabin Oral Sunday where we lined up at the school, all of us, and got our sugar cube with a vaccine. The fears at that time were so overwhelming that the vaccine was seen as a solution. And maybe one of the pieces when we're working with COVID vaccine is that people think there are other ways to avoid it. So you have, one school of thought where people think it's not a serious disease. You have another one that's like, well, I'll just, if I get it, I'm not going to die. And then you have people that are, as I said, especially with children, fearful that the impact of the vaccine would be worse than if they got COVID, and then maybe they can stay away from it. So I think you're going to have to come up with solutions for every one of those individuals. I don't think there's one answer. And I think answering all of those questions at the same time is almost overwhelming. So maybe trying to focus on the people now with young children, the 6 months to 5-year-olds. I think that's going to be a big audience. It's my understanding that there are a lot of pediatrician offices that haven't even ordered vaccines, so that the orders are not as high as we would like for them to be, especially with school starting very soon. So it's going to be one. This is kind of a dumb analogy, but if you used a dartboard, and you've got 3 or 4 darts, each one of those being the key message that you want to get across, you're going to shoot for the center of the target. We don't even say target populations. We advise against it. But I'm talking about a dartboard. Just want to qualify that. So you can get your darts as close as you can to the center, but I think you've got to shoot them one at a time.
And then this is a separate question. I don't have access to that link, or at least I don't have it immediately on hand, but if we could share it with the group via email afterwards, I think that would go, like the webinar you just mentioned. That's next week.
Sure. Yeah, I can. I'm not an organizer of that. I was asked to help with some of the technical assistance, but I will send you that. I think it's going to be worth tuning in.
And I'll put it on the P4VE calendar for those folks who actually check that.
Okay.
And then I think we have time for maybe a couple more questions.
Yeah.
Do you see a role for implicit bias training for providers and health professionals to ensure some more inclusive communication?
What a good question. Those of us who have had that learned things about ourselves. It's not all that new for somebody like me working in, when I went into nursing in 97, I came from, as my extended bio told you, and I came from such a different world, but, also understanding an audience and how to talk in a respectful way, because I'm trying to convince you to do something. I'm trying to get in advertising or marketing. I'm trying to get you to buy this product versus that product, right? And it's a highly competitive universe. The same is true in the other, when you work in an ER, especially urban ERs where I always worked, you have to go in with an open mind to be successful. Not everyone that shows up in the ER with asking for pain medication is a drug seeker. They're just not. Some people have been suffering for a long time and they need to be treated with the respect. They need to be treated, in my opinion, with respect. If they are drug seeking, you don't know what led to those behaviors and what access they've had to treatment. Many of them have not had access to treatment. So you don't know what mental challenges might underlie some of the choices that they've made. So if you come into any area where you want to help people with their behavior, and I'm assuming if you're working in public health, you want to help, having, saying this person because they don't want to get a vaccine is foolish or, not insightful or not paying attention or misinformed, that's your own bias, because you just don't know where they come from until you ask. So that, I'm circling back to what I said a minute ago, I think you've got to ask the right questions, and then you've got to recognize where you are inhibiting that person giving you the right answer, the answers that you need to hear, because I think that's where the bias has the most impact. If you don't feel like you can talk to me, and, if you're, let me just go back to my nursing universe. If you're my patient in the ER and you don't feel like you can really tell me what's going on with you, then I'm conveying a bias that I don't even have, and I need to think about it. But if I have the bias, then I need to work on it for sure.
This is a little bit more of a basic question, but I noticed on, like I was doing a little bit of background research on these principles, and I noticed that you all mentioned that it's a living document.
Yeah.
And is that, what's the process for changing it? Is that just like as we notice? Is it kind of like we feel things are changing, or is there a more formalized process for it?
What a great question. It's both. When we've gotten some really good feedback or inputs or suggestions, whether it's been internal to CDC or from meetings like this, we say, wow, that's a good idea. Then we go through and be sure that we can back it up appropriately, because we don't want to just throw something out there that we can't support. So we'll make a change. That's the beauty of the internet. When you used to print brochures, you had to throw them all away. So you might update them once a year. We can update frequently, and we have. In fact, we also committed when we launched it to doing a very official, if you will, annual review. And our annual review is completed, and the website tickets are in to make the changes, as is this table that we've been trying to figure out how to represent on the web, because if you try to do a PDF, the web team is like, that doesn't work in mobile, in the like in a mobile tablet or in a cell phone. So we're trying to find ways to get that information out there. But we made this matrix that I showed you one sample of, but we made one that's better. We'll show you the questions you should be asking yourself when you choose a graphic. Does it meet these expectations? And you're not going to get all yeses across the board. But if you're more yeses for the audience that you are trying to communicate with, then then it's probably okay to use the photo or the graphic. So yeah, we've got all these changes. In fact, the web team has sent back the development site, and it's in review with us right now. And Sarah Bedrosian is a co-lead with me in this work, and another person that works with me, Paula Erickson. We've been over it like multiple times, and it just, so we're going to be hopefully going live with it in a few days. I can let Trevor know when it's live, because these changes, they're important ones. And as I said earlier, culture rules, and culture is changing, language changes. Things that were funny, as I said, a few years ago, they're just not funny. So we're not trying to be funny in the guiding principles, but if we're not paying attention to language, if we're not looking at how things evolve, then we're not doing a good job with this website. So we're trying. And so if you see something that we need to take a look at, we're happy to do so.
Perfect. With that, I've asked all my questions, and I think we've got only about 5 minutes left. So I just want to thank you once again, Dr. Laird, for taking the time to answer all of our questions. And with that, I'm going to pass it back to Trevor.
Thanks, Eric. And yeah, just to close out, thank you so much again, Dr. Laird. This was an excellent webinar, amazing information presented. And I think, again, it's really beneficial for the line of work that we do. So thank you all so much. And thank you all so much for joining. I really appreciate your time today.
Thank you so much. I really appreciate the opportunity. And if you think of something you wished you had asked, just send it to heguidingprinciples@cdc.gov, or send it to Trevor. She'll be happy to send it to me. And I will send you the slides. I'll do that right now.
Okay, perfect. So I'll be sending out the slides and the recording to all of the participants. It will also be housed on the iReach Hub team site and sent out in the Friday weekly recap email. And Erica, it'll be on the paid website, correct?
If you send it to me, I'll upload it.
Perfect. All right. Thank you so much, everyone. Have a great afternoon. And thanks so much again, Dr. Laird.
Thank you.
Thanks, Dr. Laird.
Bye.
Bye, everyone.